Assess the adnexa. Ovaries. Anatomy and location of the ovaries. In the normal pelvis, the ovaries are most likely to be elliptical in shape and sit close to the lateral pelvic wall. The ovary is attached to the uterus by the ovarian ligament and attached to the lateral wall of the pelvis by the suspensory or infundibulopelvic ligament, which is an extension of the broad ligament. The suspensory ligament contains the ovarian vessels. These ligaments are normally not rigid, which should allow the ovary to be mobile. Identifying the presence of an endometrioma is an easy, reproducible way of identifying endometriosis. Endometriomas are a marker of more advanced endometriosis. Only a small minority of patients with an endometrioma in their ovary have exclusively ovarian endometriosis. The classic appearance of an endometrioma is a well-defined, smooth-contoured, unilocular cystic lesion containing diffuse, homogeneous, low-level internal echoes, often referred to as a ground glass appearance. Occasionally, a fluid level can be seen. The location, number, size, and appearance of any endometriomas should be documented. Endometriomas are generally non-vascular. All pelvic lesions should be interrogated with color or power Doppler using a low PRF to show slow flow. An increase in Doppler flow or papillary projections within a lesion may lead to a different diagnosis. Adnexal and ovarian lesions should always be thoroughly investigated in sagittal and transverse, applying the ORADS and IOTA criteria to acquire the most accurate diagnosis. If the ovaries are tethered by adhesions or nodules of endometriosis, they may be difficult to see or they may be located in an unusual position, such as superior or posterior to the uterine fundus. They may also be located lower than usual if they are tethered to other pelvic structures, such as the rectum or uterosacral ligaments. Often associated with endometriosis is the kissing ovaries sign, which is suggestive of severe pelvic adhesions. Ovaries are said to be kissing when they are located in the posterior cul-de-sac immediately next to each other and do not move separately. It is important to know that bowel and fallopian tube endometriosis are much more common among patients with kissing ovaries. The fallopian tubes. In the normal pelvis, the fallopian tubes are narrow, tubular structures which extend bilaterally through the superior border of the broad ligament. A fallopian tube is approximately 11 to 12 centimeters in length and consists of multiple continuous segments. The fallopian tube begins proximally at the fundus of the uterus with the interstitial segment extending from the cavity of the uterus through the myometrium. The isthmus is the short, thin segment just outside of the myometrium. The next segment is the ampulla. The ampulla is the longest portion of the fallopian tube. The distal segment of the fallopian tube is the infundibulum. The infundibulum opens into the abdomen. The fimbriae are the finger-like projections attached to the distal opening of the fallopian tube. Adhesions can distort the fallopian tubes and occasionally cause tubal occlusion. If this occlusion occurs near the distal end of the fallopian tube, a hydrosalpinx or hematosalpinx may develop. A hydrosalpinx is a well-circumscribed cystic structure and can appear as an echolucent tubular tortuous space with incomplete septations, and will often have the classic cogwheel appearance, meaning that, when imaged in cross-section, there are small projections from the wall into the lumen of the tube. A hematosalpinx will contain blood, which is a particulate fluid, causing the appearance of low-level echoes in the fluid. Color Doppler should be applied to demonstrate that the structure seen is not an enlarged blood vessel. The longest length of a hydro or hematosalpinx can be measured using a tracing caliper tool to best represent the actual length of the tortuous structure. Alternatively, multiple straight distances can be taken and added together to represent the true length of the fallopian tube. The diameter of the tube should also be measured at the widest point. Other adnexal structures. Ureters can also appear as tubular structures in the adnexa. They can be followed from the pelvic sidewall to the bladder, and color Doppler can be applied to the inferior bladder to show ureteric jets. Sit on the structure in its longest plane for a moment. If the structure shows peristalsis, it may be a ureter or a fluid-filled loop of bowel. Any peritoneal cyst, loculated fluid collection, hydrosalpinx or hematosalpinx should be documented. Ovarian mobility. The space around the ovary can be assessed for the presence of adhesions by evaluating its mobility relative to surrounding structures. Ovarian mobility is observed in real time and is best documented in video format using cine clips. When the ovary and surrounding structures move freely, the ovary is mobile. When structures are tethered and do not move freely, the ovary is non-mobile. If you are unable to show or evaluate ovarian mobility, this may be limited ovarian mobility. To demonstrate ovarian mobility, locate the ovary, identify the surrounding structures. In most normal anatomy, in a transverse or transverse oblique plane, you will be able to see the ovary between the iliac vessels and the uterus. Using the vaginal probe in this plane, slowly and gently press directly on the ovary and observe whether there is motion medially relative to the uterus and laterally relative to the iliac vessels and pelvic sidewall. It may be easier to assess each side of the ovary individually by pressing between the ovary and the pelvic sidewall, then pressing medially to the ovary between the ovary and the uterus. In this case, you may see the ovary move away from the surrounding structures, demonstrating that the ovary is mobile. If the ovary is completely attached to another structure, such as the uterus, the pelvic sidewall, or the bowel, there will be no movement between the structures and they will move together, revealing the ovary to be non-mobile. If two structures are separate from each other, but they appear to pull on each other when pressure is applied, this area can also be documented as non-mobile. There may be adhesions holding the two structures together. It may also be helpful to watch the ovary as the patient performs a Valsalva maneuver. This may be helpful to move the surrounding bowel around the ovary and may be more comfortable for the patient than applying pressure vaginally. To perform this maneuver, hold the probe still over the ovary and indicate to the patient to take a deep breath in and push out their stomach. As they push, watch the structures surrounding the ovary move. Then, as the patient relaxes, watch the structures moving again around the periphery of the ovary. Assess all sides of the ovary by turning to the sagittal plane and again pressing slowly and gently to show the motion of the ovary relative to any surrounding bowel and other tissues. Press and release multiple times to allow the chance to investigate the mobility of all borders of the ovary. Alternatively, if the ovary is located high in the pelvis, the probe can be held still on the ovary and pressure can be applied by the patient or the examiner by gently pushing on the lower anterior abdomen on the same side as the ovary being investigated. Using a combination of these techniques may be valuable depending on other factors such as the patient's body habitus and tenderness during the examination and the distance of the ovary from the vagina. Site-specific tenderness. During the acquisition of images and while evaluating mobility, it is important to document patient discomfort. If the patient is experiencing pain or tenderness in a specific area, it can be documented with the acronym SST, short for Site-Specific Tenderness, on a representative image. This will allow for easier reporting at the end of the scan when you're documenting site-specific tenderness on the technical impression or final report. If the patient has overall pelvic tenderness or is very sensitive in most areas of the pelvis, this does not need to be documented multiple times but can be described as diffuse pelvic tenderness in the report.